Hi guys, welcome back to my channel. It's your girl Nadine, and if you're new here, welcome. My name is Nadine. I'm a qualified midwife here working in the UK, and welcome to episode 2 of this mini series that I'm doing. Episode 1 was about the postnatal ward and what a postnatal ward midwife actually does. So in today's video, I'll be filming episode 2 and what an antenatal ward midwife does. I'll ask you guys to send in your questions, and I'm going to read them here today and answer them and tell you guys a little bit about the antenatal ward, what I do, and all of that good stuff. So be sure to hit that subscribe button if you're not subscribed already. Also hit that thumbs up button and let me know whether you like my videos or not. And also be sure to check out episode 1 if you haven't done so already. I'll link it up here, and I'll also link it in the description box below. So without further ado, let's get started with today's episode. Okay, so before I get started, let me just tell you guys where I'm currently based and what I do currently now as a midwife. So I'm based on the postnatal and antenatal ward, so I do a bit of both. I do postnatal and antenatal, so I know the role for both postnatal and antenatal very well. I've been doing it a little over a year now, and I've been enjoying it, and it's something that I requested to do when I finished my preceptorship program. So yeah, I'll be answering all the questions you need to know about working as an antenatal ward midwife. I have all the questions that you guys have sent me on my phone, so I'm going to go through them, answer them, and give you guys my experience and kind of tell you guys my role and what I do in my hospital. So the first question is, what is a typical day on the antenatal ward? So a typical day on the antenatal ward is I will come on shift, and I will go into the handover room, and I'll begin to take handover from the midwives that were on shift before me. So if I'm coming on a day shift, I'll take handover from the night midwives that have been on the shift before me, and they'll give me basically a detailed handover of what's been going on, the kind of women that we have, the cases that we have, the inductions that we have, the antenatals that we have, the women that are waiting to go to labour ward. They'll basically give me a detailed handover of everything that I need to know and all the women that I'm caring for and what I need to do for that day. So I'll get a very detailed handover when I start my shift. After I get a handover, I'll then go and see my women. I'll go and introduce myself. If I'm working with a student, I'll go with the student and we'll both introduce ourselves, and we'll obtain consent for care, and basically just getting to know all the women and asking them if they need anything, telling them that I'm going to be the midwife that's going to be looking after them and things like that. And after I've introduced myself to all the women, I'll then go and look at the notes. I'll speak to the doctors. We'll come up with a new plan for the day. Those that are waiting to go down, I'll call labour ward, and I'll make sure that they're aware that these women are waiting to come down to labour ward to have their babies and things like that. So after I've done all the introductions and I've read through their notes and I've spoken to the doctors and we've got a new plan, I will then basically start undertaking and fulfilling my tasks for the day. So if there's women that need to be on a CTG, I'll start my CTGs. If there's medication that's due, I'll do those. If women needs to be transferred to the labour room and they're ready to be transferred, I'll start transferring them on downstairs to labour ward. And basically that is a typical day of a midwife. That's basically what I'll be doing until the end of my shift. And at the end of my shift, I'll basically hand over the care and everything that I've been doing to the night midwives that have come on shift. If I'm doing a day, I'll basically go into the handover room and I'll basically hand over the care that I've been doing and the women that have been under my care and what needs to be done moving forward. So that is basically a typical day of an antenatal ward midwife in a nutshell, but I'll go through every single thing in more detail, including the actual duties that we do, why we do them, and things like that. So that's just the first question, as in the typical day as an antenatal ward midwife. So the second question is, what is the patient to midwife ratio? So this is based on my hospital and where I work. Obviously every hospital is different, they do things a lot different, they may have different ratios, they may have a bigger maternity ward, they may have a bigger antenatal ward, so they may have more midwives and more patients, but this is solely based on where I work. The patient to midwife ratio. So on my shift I can only have a maximum of, I believe, 6 or 8 women at a time. Obviously when we are short and there's a lot of women, there has been times where I have had 11, 12 women and I'm just the only person looking after them. This has happened before. I'm not trying to scare you guys, but when we're short, we just kind of had to go with the flow and get on with it. So, but the ratio that we are supposed to have within our hospital is 6 to 8. I think 8 is the maximum. However, this can change depending on staffing and depending on how heavy and how hectic the ward is. But that is the patient to midwife ratio where I work. So the next question is, what is the typical tasks on the antenatal ward? So let me just list a few of the typical tasks that we do on the antenatal ward. We administer medication, so we do like drug rounds. We administer IV fluids or IV medication like antibiotic. We also use CTGs, so women that need CTGs, we do those, and we analyze CTGs, and if there's any issues, complications, then we need to be referring the women to the doctors so that things can happen. We do examinations, so we do vaginal examinations. So if a woman is progressing, or if we are administering medication such as Propes or Prostin for the women that are being induced, so we undertake vaginal examinations prior to administering the Propes or Prostin, just to make sure that this woman can actually have the medication. Or if she is waiting to go down to labor ward, we have to make sure that she is in active labor before we send them down, so we need to do a vaginal examination. We induce women, so we do inductions. So inductions is when women come onto the ward for various reasons. For example, they are GDM, they're diabetic, and they need to be induced. They can't go over a certain gestation, so they come to the ward to be induced. Or if there is, you know, complications such as PET, OC, or reduced fetal movements, and they come to the ward to be induced, then we do inductions on the antenatal ward, and we basically prepare them to go into labor and to be taken to labor ward. So we do antenatal care, so women that come onto the ward who are antenatals, who are not there to be induced. Say for example, they have come with a high blood pressure reading, or they're dehydrated and they need fluids, or they need antibiotics for some reason, or they need follow-up, or women that have very, very bad hyperemesis. We get a few of those that come onto the ward, and we basically look after them by giving them anti-sickness, by having them be seen by a doctor and being reviewed, making sure that their hyperemesis is controlled and that they're not having a difficult time when they're at home. So basically, various of reasons, antenatals will come onto the ward and we will care for them. Those that are not in labor but have a few things going on within their pregnancy and they're having to come in for monitoring or medication or to be seen by a doctor. So we see antenatals and induction ladies. Those are the two main, you know, clients or patients that we see on the antenatal ward. So the next question is, what are the shift patterns on the antenatal ward? So the shift patterns are basically the same as if you're working on the labour ward, if you're working on the postnatal ward, they're basically the same. So the shift pattern is 8 AM to 8 PM, or a night shift, which is 8 PM to 8 AM. So it's just basically the same all around in maternity. You do your 12-hour shifts, you do your long days, you do your nights, and if you are contracted to either do an early, then you do an early, and if you're contracted to do a late, you do a late. So the shift pattern is basically the same as you would do on a postnatal ward and also on labour ward. Okay, so the next question is, can you be an antenatal ward midwife after qualifying? So the answer to this question is yes, you can be an antenatal ward after you finish your preceptorship program, but some hospitals require band 7s or more senior midwives to work on the antenatal ward, because it can be quite high risk, and they can, you know, they do need a lot more senior midwives working there because of the high risk patient that they get and everything that could go wrong, they need more senior midwives. But for my hospital, after finishing my preceptorship program, I was assigned to work on the antenatal ward, even though I'm a senior midwife. Even though I'm a junior midwife, sorry, I think I said senior. Even though I'm a junior midwife, I work alongside someone that's more senior, so we basically share the workload. If I have questions or if I'm not sure about things, I basically ask the senior midwife who I'm working with. And just to make something else clear, on the antenatal ward we are 2 midwives where I work, and we basically run the whole ward. So in the previous episode I mentioned that the postnatal ward, they are allocated 3 midwives on the postnatal ward, but on the antenatal ward we are 2 midwives. 1 senior midwife and 1 junior midwife can work on the antenatal ward. They don't really like 2 junior midwives working on the antenatal ward, just because of the high riskness of the antenatal ward and the type of things that you have to deal with on the antenatal ward. So they much prefer to have a more senior midwife there managing, and also a more junior midwife can also work there, as long as there is a more senior midwife that can support the junior midwife in the role and things like that. But to answer your question, yes, you can work on the antenatal ward after finishing your preceptorship program. However, every hospital is different. Some hospitals only allow band 7s or more senior midwives to work on the antenatal ward. I think this is the same where I trained. Where I trained, they only allowed a band 7 or a more senior midwife to work on the antenatal ward. However, where I currently work now, a senior midwife and a junior midwife can both work on the antenatal ward. I hope I answered that question for you. Okay, so the next question is, do you get breaks on the antenatal ward? So the answer to this question is yes, you do get breaks. You're supposed to have breaks, whatever job you do. If you go without a break, then you need to talk to your manager. Something has gone very, very wrong, but you can't work a 12-hour shift without break, because that's just insane. I mean, I don't even know if that's legal. You're supposed to have a break if you're doing any kind of job, I think, but especially in maternity, or especially working a 12-hour shift, you definitely deserve a break, or you definitely must get a break. So on the antenatal ward we get a break. So if one midwife is having a break, there's only one midwife on the floor making sure that all the women are okay while the other midwife is on break, and then they will just basically rotate, and that's basically how we have our break. Our breaks are an hour, so we have an hour each, and then that's basically how we do it in the hospital. We do get a break, and you are supposed to get a break. If you're not getting a break, then something is obviously very wrong, and I would say speak to your manager about it. So the next question is, do you wear uniform on the antenatal ward? The answer to this question is yes, we do wear uniform on the antenatal ward. So the uniform that I would wear for the postnatal ward is the same uniform that I would wear on the antenatal ward. So the picture that I put up last time is this. So this is the uniform that I would wear on the antenatal ward. It's the same uniform that I would wear as a postnatal ward midwife. It doesn't change. We wear the same uniform. Next question is, do you have students on the antenatal ward? And the answer to this question is yes, we do have students that need to learn how to work as an antenatal ward midwife. So I've had students before as an antenatal ward midwife, and they'll basically work alongside me. I'll teach them what I know and what I can teach them, and they'll basically be shadowing and getting hands-on experience while working with me. So yes, we definitely have students that work alongside us on the antenatal ward. So the next question is the antenatal ward fast-paced? I think the antenatal ward is not as fast-paced as the postnatal ward or as on labour ward. So the antenatal ward, you have women that are just basically there for observations, or you have women there that are waiting to go down to labour ward, and you might be just doing, you know, CTG every 6 to 8 hours, or they have ProPes in and they have to wait 24 hours to be examined again for prostin, or they have prostin and then you have to wait 6 hours for them to be examined again to see whether they're ready for labour ward. So it's not as fast paced as the postnatal ward, but it can get quite busy the more complicated cases that you might have, or the more women that you may be looking after. So it can be quite fast, but I don't think, in my opinion, is fast-paced compared to the postnatal ward or labour ward, because most of the women that we get on the antenatal ward are there for, you know, observations which don't happen every 2 seconds, or they're there for inductions. And inductions, once you start a woman in, you know, during her induction period, you basically just wait for her to be induced and for the medication to work and for her to go into labor. So you're basically just monitoring her and baby every 6 to 8 hours. You're basically waiting for something to happen for her body to go into labor and to react to the medication you've given her. So I don't think the antenatal ward is as fast paced compared to postnatal ward. Okay, so the next question is, what emergencies have you had on the ward? Oh dear. So I've had a lot of emergencies working as an antenatal ward midwife, because of course you're dealing with women that are still pregnant, you're dealing with women that are being induced so they can go into labor any minute now. So the kind of emergencies I've had women almost deliver on the ward and they almost didn't make it to labor ward, and I've had to pull the emergency buzzer and get someone to call labor ward and having to transfer this woman immediately to labor ward. That's happened numerous times. I haven't had anyone faint on me, I haven't had anyone pass out on me. I've had deliveries on the antenatal ward, so women that didn't make it down to labor ward, I've had to deliver on the antenatal ward. By the way guys, just putting it out there, we are not supposed to be doing any deliveries on the antenatal ward. Women should be prepared for labor ward. So if they're being induced, they should only be prepared and induced for labor ward. They shouldn't actually be delivering on the antenatal ward. But sometimes women can just progress just like that, like so quickly. It's happened to me so many times, and you basically have no choice but to deliver a baby right there in a 4-bedded bay while other people are listening, and you just have no choice but to deliver in the bay. It's happened to me a few times. There's sometimes where I've made it to labor ward and she was in her own room and she managed to make it on time. But yes, there's been some time where I've had to deliver on the ward, and it hasn't been great, but you know, nothing went wrong. Baby was fine, mum was fine, and it was a beautiful delivery. There was no complications, but obviously women would like to have their own private space to deliver their babies, but when babies come like that, what else can you do? So the next question is, do you ever finish later than your finish time? So yes, there's been times where I finish later than my finish time because of various reasons. For example, if I've had to stay back to finish my documentation, if I've had to transfer a woman, say for example, if I transferred her at 7:30 and I'm finishing in 30 minutes, but obviously the baby's coming, I can't just be like, I'm not going to transfer her. If she's, you know, still under my care, I still have to continue and make sure she has a safe kind of transition. If she's going into labor on my shift, I have to make sure I stay there and make sure she makes it to labor ward. So there's been times where I've been on labor ward transferring a patient, and then she is pushing and there's no one there to take handover, and I'm having to stand there and basically deliver this baby, and it's 8 o'clock and it's my finish time and I'm here doing a delivery. So yes, there's been times when that's happened and I've had to finish later than my finishing time. Obviously in those kind of situations, they do give you your time back, or you get paid the extra hour or 2 that you stayed. So yeah, there'll be various reasons where you finish late, but I tend to always try and finish on time. Like I finish on time about 96% of the time, which is good. So the other 4% is just basically either I've been rushed off my feet, I've got a lot of documentation to catch up on, or I've been short and I've had to transfer a lady downstairs and deliver her, or there was no one to take handover from me quickly, and things like that. Okay, so the next question is, do you work with other professions on the antenatal ward? So other professionals that would be on the antenatal antenatal ward, working alongside me will be maternity support workers. They will be doing things like maternal observations, making sure that they are properly taken and documenting, and obviously letting me know if there's anything out of the norm, or if there's any client or patient that needs to be reviewed immediately. Maybe her observations are in the red and something needs to be done, so they do things like that. They make sure that the meals are given to the right patient. They make sure that their beds are being changed, cleaners are coming in to change beds and things like that. I also work alongside doctors, so doctors come for doctors round in the morning or whenever they need to be coming on the ward to review women. So doctors will review women who have come in, and if they need certain medication, they'll come on the ward, prescribe it, or if they need to be induced, they come onto the ward and basically talk about the induction process with the women, prescribe the medication and things like that. The other professionals that I may work with is the safeguarding midwives. If there's a woman who's under the safeguarding team, she'll also pop by, see that the woman is okay, if her care plan has been noted and things like that. Also the diabetic midwife will also pop by. If there's a woman that's under my care that's GDM or diabetic, the diabetic midwife will come onto the ward, have a chat with the woman, let me know about their care plan, if anything needs to change and things like that. And who else to work with? We also work with the ward managers, the matrons. They also come onto the ward some now and then, and just to make sure that everything is running smoothly. So those are the kind of people or professionals that we work with on the antenatal ward. It's basically the same as the postnatal ward, just a little few different touches and different people that work on the antenatal ward. Okay, so the next question is, do you prefer working on the antenatal ward or the postnatal ward? So in the beginning, when I started working as a newly qualified midwife, like when I was fresh from school, I basically preferred and I was more comfortable on the postnatal ward, only because as a student midwife I hardly got any experience working on the antenatal ward, and I was basically terrified of working on the antenatal ward. I was so scared. So when I was doing my preceptorship rotation and I was allocated to work as a preceptee on the antenatal ward, I was like, I need to take note, I need to make sure that I know what I'm doing, because I'm gonna not be a preceptee no more. I'm gonna be basically left on my own to look after these women, and I need to basically, you know my stuff. But the times I've been working on the antenatal ward, I've actually loved it, and I've actually enjoyed working on the antenatal ward. And I think I prefer working on the antenatal ward compared to the postnatal ward, only because I enjoy things like CTGs, and I enjoy labouring women, and I enjoy inducing women, looking after antenatals and things like that. I actually enjoy working on the antenatal ward. Not saying that I don't enjoy working on the postnatal ward. Obviously I enjoy working there, I requested to work there. However, if I had to choose the antenatal ward or the postnatal ward to work full time, and my manager was like, right, you need to pick one and that's going to be your permanent position, you can't rotate to both, I'll be like, put me on the antenatal ward. Only because of what we do on the antenatal ward, I actually really enjoy it. Like, I learned so much, and it's a puzzle all the time. Your brain is constantly moving, you're constantly thinking, and you're looking after pregnant women, and they're about to have their baby, and it's like the excitement process and things like that. But yeah, that will be my preference. If I had to choose, I'll choose the antenatal ward. Okay, so the next question is, how long did it take you to be comfortable working on the antenatal ward? So it took me a lot longer to be comfortable working on the antenatal ward, only because I was so nervous and so afraid of working on the antenatal ward because of the lack of experience or the lack of practice that I got as a student midwife. So I was more comfortable working on the postnatal ward because I've been doing it for so long as a student midwife. I was very much ready to go. So on the postnatal ward, it took me like about 3 months to get proper comfortable and in my zone, and on the antenatal ward it took me a lot longer, probably double that. It took me about 6 months to actually be comfortable and, you know, feel that I can do it and know my stuff a little bit better. But yeah, it took me a while. It took me about 6 months to actually, you know, have a routine and not be so afraid every time I walk onto the antenatal ward and every time I take handover. It took a while. It took a lot longer for me compared to the postnatal ward, but now I'm so comfortable working. Obviously every shift is different. You still get your little nerves. What am I getting today? What are the cases, or what's been happening? Have women been here for so long waiting? Are you going to get shouted out because they're still waiting to go down to labor ward? But I feel a lot more comfortable and a lot more at ease working on the antenatal ward, even though it took me a lot longer to get comfortable and to actually find my feet on the antenatal ward. So the next question is, do you ever have difficult mums or partners on the antenatal ward? So I've had difficult mums in the sense that they have been waiting for days, hours, for a couple of days, waiting to go down to labor ward. So let me just give you guys a brief description about why they would be waiting. So if women are being induced, they will be induced to the point where they're ready to go down to labor ward. However, if labor ward doesn't have a bed or a midwife, then that woman has to wait on the ward until the bed is available or the midwife is available. If the bed is not available and the midwife isn't available, they have to basically stay on the ward. So I've had mums that have been on the antenatal ward for about 3 days, going on to 4 days, because there's no bed, there's no midwife, and there's just a delay in transfer. So obviously it's understandable, like the wait can get people very frustrated and very annoyed, and they tend to take it out on the midwife. I don't know why, they always do. If you see this video, it's not the midwife's fault on the antenatal ward. All we can do is tell the labor ward coordinator that you're waiting to go downstairs and that you need to go downstairs, and it's up to them to facilitate that and to make sure that there's a bed for you. But obviously the women on the ward can get frustrated, and obviously they take out their frustration on the midwife that's then looking after them. And I've had women that have, you know, threatened to go home, to go to a different hospital because of the wait. They've been waiting for so long and they're tired of the wait. I've had women scream and shout that they have waited for ages and that no one's taken them seriously. So that has happened before, and we basically try and diffuse the situation, and we basically, you know, try and get them down as soon as we can. Obviously this is out of our kind of power. It's up to the availability of the rooms and the availability of the staff downstairs, and if there is a delay, we have to just let my manager know, let the matron know, so they can then escalate it. They can then go downstairs and see what they can do in terms of transferring people. So I've had difficult patients in that sense. I haven't had difficult patients in the sense where they were just rude for no reason, or they were just being difficult for no reason. Like, women are very understanding and they're very patient and they're very nice in that kind of environment when they're having a baby. It's only when the frustration kicks in or the pain kicks in that they can let it get to them, and then another side of them comes out. But obviously I try and diffuse the whole situation by, you know, speaking to them, explaining to them, you know, telling them everything, the real, and having them understand the situation. And if I can't diffuse it, obviously I let a more senior midwife deal with it, or my manager come and speak to the lady, which I've done before. There's been times where a woman was threatening to go home because she's been waiting for about 3 days, and she was like, you know what, I'm packing my stuff up and I'm going home. Obviously she can't go home, she's had medication that could affect her and baby, and we need to monitor her, and I'm trying to explain all of this to her and she's still not having it, and I've had to get my manager to come and speak to her, and she actually managed to stay on the ward. But yeah, not a lot of difficult patients that were, you know, out of order for no reason, just those that have been frustrated and annoyed about the whole system and everything being delayed. Okay, so the next question is, do you ever get pulled to another ward if you're short staffed on labour ward? So yes, the answer to this is yes, we do get pulled down to labour ward if the labour ward is short staffed. So there has been times where you start off as 2 midwives on the antenatal ward, and if labour ward is short, they will pull a midwife down to labour ward and you'll be stuck there on your own, looking after the whole ward on your own. This has happened to me, and I'm not going to say it has happened to me once. No, it has happened to me numerous of times. Obviously there's a shortage of midwives in the UK, and things like this happen where staff come onto a shift and there's not enough staff to cover the wards and to work in a safe environment. So when labour ward is short, they tend to pull from all the different departments to make sure that they have safety numbers appropriate to labour ward. So if they can't pull anywhere else, they'll start with postnatal ward, and if they can't pull on postnatal ward, maybe they're full, they will then pull on the antenatal ward. And I've been left on the antenatal ward on my own, looking after for about 11, the most I've had was 14 women on my own on the antenatal ward. It hasn't been great. I've had to call the manager on call and basically let her know that I'm on my own. She's had to then come in. Sometimes they don't come in, they basically just leave you there to kind of get on with it, or they send in a midwife that's on call to come and help you if they've pulled anyone. So there are certain times where there are midwives that are on call, they get called in from home to come and help you, or the managers and matrons will come in from their homes and then come and help you. But there have been times when no one came in to help me, and I've been on my own for the whole entire shift. But yes, that will be another day for another story. But yes, there has been times where I've been pulled to labour ward, or they've pulled my colleague and I've been left on the antenatal ward on my own. Okay, so the last and final question is, do antenatal ward midwives get paid less or more than the postnatal ward midwife or any other midwives in maternity? So the answer to that is no. The midwives working on the antenatal ward and postnatal ward and labour ward, they all get paid the same amount. We all get paid the same amount. Obviously there are different bands, there are different experience levels. If you've been there for like 10 years, 5 years, you get paid a little bit more than someone that has just started. But yes, everyone basically gets paid the same. No one gets paid different only because they're an antenatal ward midwife, or there's a postnatal ward pay, or there's a labour ward pay. Everybody basically starts at the same pay grade. Obviously, unless if you are a different band or if you have more experience, then you get paid differently. But basically everybody gets paid the same amount when they start. Okay, so this part of the video, I'll basically be telling you guys about the induction process and what basically happens when a woman comes onto my ward for an induction or to be induced for any type of reason. So I briefly mentioned the different reasons a woman can be induced. So things like diabetes, a woman can be induced. They don't want her to go over 37, 38 weeks. Reasons such as if a woman has severe PET that can't be controlled and the baby has to come out, then they'll be on the ward to be induced. Or if a woman has OC, then they'll be on the ward to be induced if they haven't gone into labour. Other things would be like if there's reduced fetal movements multiple times, then there will be a woman on the ward being induced for reduced fetal movements. There's also things like for maternal age, women can be induced because of maternal age, and also women can be induced for maternal requests. So if a woman requests to be induced, they can come onto the ward and then be induced. So the whole induction process, I basically see the women, they come onto the ward, I go through their notes, I ask them about the reason they're being induced, I take a brief history from them, and then I sit down in the notes and I take a more detailed history about the care they've had and everything. After that, I then make sure that they are aware of the whole induction process. So I would sit with them and their family or their birthing partner they've come with, and I will basically explain the whole induction process. I would give them an opportunity to ask me questions, and I will make sure that they have consented and they are aware of everything before I proceed with the induction process. So after I've done that and they're happy with the induction process, they know what they're doing, they know their reasons, everything, they know the medication, they know what support and the whole system and how everything works in terms of induction, I will then proceed and continue with the induction process. So I will then make sure everything is prescribed for the induction process. So I will make sure that pethidine is prescribed in case we need pethidine and the anti-sickness that goes with pethidine. I will make sure the induction medication is prescribed. So I will make sure the Propes is prescribed by a doctor. All of this is prescribed by the doctor, and any pain relief such as paracetamol and dihydrocodeine prescribed and ready to go. After I've had everything prescribed, I will go to the woman. I will do a head-to-toe check, make sure that her observations are okay, start a CTG, make sure that the Dawes-Redmond criteria is met. After the CTG, I will also scan mum's belly and make sure I can visually see the head is down. So in my hospital we have a little mini scanner. We scan and see that the baby is in the position that baby needs to be, and then I basically look, okay, that's the head. I show mum the head is down, and then I will then, you know, give the medication. So I will not induce anyone that is breech. If a woman is breech on scan or on palpation, I will not induce her. If baby is cephalic, so head down, then I have the green light to induce. So after I've confirmed that CTG is beautiful, baby is head down, mum is well, obs are fine, I then will give the first line drug, which is the Propes. So I would give the medication, I will do a vaginal examination, find her cervix, figure out the Bishop score, and then I would administer the Propes. So I'll do that. After I've inserted the Propes, I will then do another CTG to make sure baby is happy with the medication, and after I've done the CTG, everything's all well, I'll just leave mum to do whatever she would like to do. She can go to sleep and have a nap, she can walk around the ward, she can walk outside but not go home. She can't go home. After the induction process aside, she cannot go home because she's had some medication that can affect her and baby, so she can't go home, but she can walk the grounds of the hospital, she can go to the shop outside the hospital, she can use the birthing ball, she can go to our lounge or watch TV, or she can have a nap, she can have dinner, she can do whatever she likes. And I basically monitor mum and baby every 6 to 8 hours, and the Propes basically stays for 24 hours. After the 24 hours is finished, I will then take the Propes out, examine, see how the cervix has changed, if there's any change, if there's any contractions, and I will figure out the new Bishop score. If the cervix is still very posterior and still closed, I will then administer the second medication, which is called Prostin, and then I'll give the Prostin, which is a gel-like medication, and that basically goes to the cervix, and that stays in for 6 hours, and that's then to also help mum get into labour. So the Prostin stays in there for about 6 hours. After 6 hours, then I will call a doctor to come and see mum and review mum to see whether mum needs another Prostin, another gel, or whether she can go straight to labour ward and have her waters broken if her waters have not been broken. So if the doctor examines the woman and her cervix is still very posterior and very closed, the doctor will offer her another gel. If her cervix has come down and it's about 1 to 2 centimeters and they're able to break her waters, then they'll break her waters on labour ward. So she'll basically just stay there until there's a bed available. She'll go downstairs, they'll break her waters, and then hopefully she'll go into labour, and if not, then she'll have a drip and she'll have some medication to help her with the contractions. So that's basically what I do in terms of inductions and inducing women on the antenatal ward in a nutshell. If you want a more detailed video about the induction process and everything to do with inductions, including why women get induced and the medication we use, and explaining that in more detail, be sure to comment down below and let me know. But that's just a brief outline on the induction process and what actually happens when we induce women. So that is the last part of today's video. I hope you guys have enjoyed this video as much as I've enjoyed talking about it. I actually enjoy the antenatal ward and I love talking about it because it's so amazing, like the whole, you know, antenatal ward care and labor. Like I love that whole stage in maternity. But I've come to the end of today's video. I hope you guys have enjoyed it. If you haven't hit that subscribe button, be sure to hit that subscribe button and join my YouTube family, and I will catch you guys in episode 3, which will be about labour ward, and until then guys, I'll see you sometime very soon. But yeah, thank you guys for watching, and I'll see you guys in my next video. Bye guys.